So I think it's 3 after, so we'll get started. Thank you everyone for joining today for this week's Grand Rounds, and I'll hand it over to Michael Kaplan, our Chief Resident, who will introduce our speaker, Dr. Horowitz.
Thank you, Dr. Deshpande. It's my distinguished honor to welcome Dr. Mary M. Horowitz, who is the Robert A. Uihlein Professor of Hematologic Research and Deputy Cancer Director at the Medical College of Wisconsin-Milwaukee. Dr. Horowitz has been involved in clinical research in hematopoietic stem cell transplantation for more than 35 years. She served as Chief Scientific Director of the Center for International Blood and Marrow Transplant Research for 30 years and is now Scientific Director Emeritus. Dr. Horowitz is Principal Investigator for the Coordinating Center of the U.S. Blood and Marrow Clinical Trials Network, a multi-center group funded by the NIH to test new therapies to improve the safety and effectiveness of transplantation and cellular therapy. She has received numerous awards for her work to advance HCT, including the American Society of Blood and Marrow Transplantation's Lifetime Achievement Award in 2014, the 2019 American College of Physicians Harriet P. Dustin Award for Outstanding Science Related to Medicine, and the 2019 Aplastic Anemia and Myelodysplastic Syndrome Foundation's Lifetime Achievement Award in Science Lifetime Achievement in Science Award. She is also dedicated to fostering the next generation of clinical scientists and received the American Society of Hematology's Mentor Award for Clinical Science in 2010 for her work guiding, supporting, and promoting the training and career development of young investigators. She served on numerous NIH advisory panels, co-authored more than 400 publications, and been continuously funded by the NIH since 1990. Please join me in giving a warm Miami welcome to Dr. Horowitz.
Thank you very much, Dr. Kaplan. How warm is it there, by the way?
It's beautiful. Mid 80s.
80s.
Yeah, it's beautiful here too, but mid 60s. So little different definition. It's actually, it really is my pleasure to be here. I assume you can all see my slides because I forgot to unshare them for the introduction, but there you go. But that means I'm all set up. So I am going to talk about real world data and the evolution of hematopoietic stem cell transplantation, or HCT, but we could also call this talk how a database of real world data provided real world evidence to improve the outcomes of transplant, long before the terms real world data and real world evidence even entered our vocabulary. So what I'm going to do today is first give a brief introduction to hematopoietic stem cell transplantation. But this talk isn't really about transplant, although I am a transplanter. But it's to give an example. It's to describe the CIBMTR, the Center for International Blood and Marrow Transplant Research, which has maintained a large outcomes registry since 1972, and to show how the availability and use of these data advanced the understanding, practice, and outcomes of transplant. And why would I want to do that? Because we're all awakening to the power of data now. And I want to show you from this long history the potential uses and the pitfalls of using real world data, not just in transplant and other cancer therapies, but in all of medicine to assess outcomes and to help us plan and conduct trials. And then I'll take the last few minutes to speculate on the future, since I was just told that's all anyone ever cares about. So transplantation, I apologize if this is a review for a lot of you. It's an intensive therapy. It's used primarily for hematologic malignancies and other rare marrow failure and immune deficiency disorders. In the elevator speech description, it's a cytotoxic or immune suppressive therapy followed by infusion of blood stem cells to restore hematopoiesis that has been destroyed either by the primary disease being treated or by the pre-transplant treatment for that disease delivered with curative intent, and can also, in some instances, provide a very potent immune-mediated graft versus malignancy effect. I keep using this. Okay. Two main types: autologous, where the stem cells are collected from the patient, usually after a lot of prior therapy, and allogeneic, where we have a healthy donor. In autologous transplants, we're really talking about a way of doing dose intensification, using doses of drugs that will destroy the marrow, and so hematopoiesis has to be restored with cells that have been collected pre-treatment and frozen. In allotransplant, yes, we are sometimes doing that, rescuing from myeloablative therapy, but also with the allograft, you have the potential for graft versus malignancy, and which can be very potent and which accounts for a lot of the efficacy of transplantation in blood cancers. Sometimes with allotransplants, you're simply replacing the marrow, such as in aplastic anemia. Allotransplants generally require close matching for HLA. It's beyond the scope of this talk, but with recent advances, we can now do mismatched transplants. So I'm not going to talk about that today, but I don't want anyone to leave this talk thinking that if you don't have a match, you can't have a transplant, because really we can find an acceptable donor these days for just about everybody. But generally speaking, we're trying to closely match for multiple HLA loci. And these loci, as I'll talk about, have varying importance. In just a review of HLA inheritance, you get your HLA haplotype as a set, one set from your mother, one set from your father. And then, just stochastically, any given sibling has a 1 in 4 chance of having inherited the same set and therefore being HLA identical, which has been our gold standard for hematopoietic cell donors. And I'll just warn you, I'm not going to talk anymore about autotransplants. It's going to be allotransplants in this talk. Given the family size in the US, that means that 70% of people don't have a match in their family. They need to find a match among unrelated people. And fortunately, starting in the 1980s, large panels of volunteer donors were identified. And actually 2/3 of the transplants that are done, of the allotransplants that are done these days, are from unrelated donors. But the chance of finding a donor, really a matched donor, varies by ethnicity, being close to 80% for non-Hispanic whites, but as low as but less than 25% for African Americans. Now, you can use mismatched donors. A lot of excitement these days about using donors that only share related donors that only share one of those haplotypes with the recipient, haploidentical donors with new approaches to overcome the HLA barrier. You can also use umbilical cord blood. Umbilical cord blood has a very high concentration of blood stem cells. This just shows the indications for hematopoietic cell transplantation in the US. There's a little over 20,000 a year. Major indications for autotransplants are myeloma and non-Hodgkin's lymphoma. For allotransplants, acute leukemia, myelodysplastic syndromes, and some non-malignant disorders. And then I'm not going to talk about it today, but there's increasing use of non-transplant cell therapies such as chimeric antigen receptor T cells for more targeted cellular immune therapy of cancer. All right. Okay, now you have your primer, BMT 101, and we're going to go back to the real subject of this talk, which is real world data. So let's start with some definitions. These are from the FDA in 2018 in their guidance on use of real world data. What is it? Data relating to patient health status and or the delivery of healthcare routinely collected from a variety of sources. And the real world evidence is the evidence derived from that real world data. All right, the terms are new, the practice is old. As said by Sir William Osler many, many years ago, the whole art of medicine is observation. We observe, we record, we tabulate, we communicate. Medicine was established by close observation of data occurring in the real world. So why is it a new thing now? Well, the problem with observing real world data is that human beings have problems with accurate observation and interpretation, and we call that generically bias. And you've all learned this in bias stats. Here's the list of some of the potential causes of bias, and we're often unaware of it. And as we all know, unconscious bias can have negative effects, not just in science. This led to the rise of the randomized clinical trial, as said by Sir Ronald Fisher along in the beginning of the last century. Randomization relieves the experimenter from the anxiety of considering and estimating the magnitude of the innumerable causes by which his data may be disturbed. Although it's been my observation that investigators don't worry too much about this, and that is why we need to do randomized clinical trials. And I'm never going to argue against randomized clinical trials. As Dr. Kaplan pointed out, I lead a big clinical trials network whose job it is to address things in a randomized fashion in transplantation, but it's not the only tool we have, and it's not possible in every situation. Even when we want to do it, there are barriers of cost, logistics, susceptibility, small populations. Now, if we could only offer our patients therapies that had been tested in randomized trials, we wouldn't have a lot to offer. And medicine would not have advanced to where it is now. But we do have to, and we also have to recognize that trials are experiments. They're artificial situations designed to isolate treatment effect, and they're very good at that. But those effects may differ once the treatment is deployed in the real world. And there are a lot of things that randomized trials simply cannot do. They can't analyze access, utilization trends. They can't identify prognostic factors in a general population, only in the population eligible for and willing to participate in trials. And I think we all know that that may not be representative of the population in which therapies will be applied. They can't evaluate the influence of treatment centers, study uncommon late effects, or evaluate the treatment effects of things that simply cannot be randomized, which brings us to unrelated donor-recipient HLA match. We'll get to that in a minute. There's a lot of sources of real-world data. Electronic health records, our very favorite thing. Laboratory data, claims and billing databases, not my favorite. Patient-generated data, including mobile devices, surveillance databases like the CDC. But we're here to talk about its registries. Now, registries can incorporate data from all of the above as well. But what distinguishes them is that they're an organized system that uses observational study methods to collect uniform data, whether clinical and otherwise, to evaluate specific outcomes for a population defined by a disease, a condition, exposure, and it serves one or more predetermined scientific, clinical, or policy purposes. Its advantage over other sources of real-world data is it's designed for research, or it can be designed for research. And of course, I'm talking about registries that are designed for research. Electronic health records are designed for clinical care and billing. They are not designed for research, as anyone who has tried to do research with EHR will know very well. Registries vary in their quality and their fitness for use, as said by the FDA, and that fitness is determined by the intended use, the completeness of the data, and the follow-up of the patients, the granularity and quality of the data, representativeness, and the ease with which data can be accessed and analyzed. Now, the Center for International Blood and Marrow Transplant Research, way too long a name, I know, CIBMTR, is a patient outcomes registry that has been around for a very long time. It's been collecting data on the outcomes of hematopoietic stem cell transplants since 1972, when it was established as the IBMTR, International Bone Marrow Transplant Registry, at the Medical College of Wisconsin. Now, I usually give this talk to a bunch of people who are transplanters, and I don't have to explain to who any of the pictures or the names are, but these were some of the pioneers in transplant, including this person, Don Thomas, who actually got the Nobel Prize for transplantation. I don't remember what year. But what's important to note is that this was just 4 years after the first successful transplants had been done in 1968 in 3 young boys with immune deficiency diseases, one from Milwaukee, where we are. At the time, there were maybe 50 transplants being done a year in the entire world. So it started really early in the field. Another important event here is, as I told you, all these transplants were from siblings that we thought were matched. Some of them probably weren't. As unrelated donor transplants began to be developed, the National Marrow Donor Program, or Be the Match, was established there in Minneapolis, their coordinating center, to be the US donor registry. Importantly for this talk, they also established an outcomes registry to track the results of the transplants that they were facilitating. Some of the same people were involved. Also importantly, they decided to establish a research repository of donor recipient samples. Why am I talking about all of this? About them? Because in 2004, the Medical College of Wisconsin, where the IBMTR was, signed an affiliation agreement with the NMDP to combine those two research programs into the CIBMTR. And we now have data on, more than 500,000 transplants. By the way, these curves back here, these are the annual number of transplants, allogeneic and autologous, being done worldwide. This little blip here, that was a transient enthusiasm of auto transplants for solid tumors like breast cancer. But it is continuing to grow. What's really important about HCT is we're not the only registry. We were established in 72. The Europeans established a registry in 74. In the 80s and 90s, there was a whole slew of national registries. And then now there are regional, international registries. It's been estimated that 85 to 90% of all of the transplants done globally, they have data reported to one or more registries. That's just phenomenal. I don't know of any other field in medicine where this is the case. So let's go back to the one I know the most about, because I've been working with the CIBMTR since 1985. This is a population-based registry with the population defined by receipt of transplant or cellular therapy. The data, let's talk about it characteristics in terms of fitness for use. We have an evolving data set that reflects the community's growing understanding of important clinical variables to consider when studying outcomes. Before 2000, we capture in the US all the allotransplants because in 2007 it became mandatory. Before 2007, it was all voluntary, and we still captured 75%. And although it's not mandatory to report auto transplant, we capture 90% of the auto transplants being done in the US, and about half of the commercial CAR T-cell therapies being done, as well as data from about 150 sites. When you're capturing that large a fraction of the target population, you don't have to worry too much about representativeness. It's a longitudinal database for as long as the transplant centers can follow the patient, they provide us data, and we have more than 15 years of follow-up on tens of thousands of patients. And we pay a lot of attention to data quality with computerized error checks and on-site audits. And we make the data, not only the data, but statistical support for analyzing the data available to thousands of investigators. So I'd say we're reasonably fit for purpose. This shows the number of patients registered. As I said, it's just under 600,000 now. Remember that research repository established by the NMDP. We now collect specimens on both related and unrelated donor recipient pairs, as well as specimens for trials of the BMT Clinical Trials Network. We have more than 60,000 donor recipient pairs that have specimens. And just last year alone, we distributed 25,000 samples to investigators. When I joined the IBMTR in 1985, I was the 8th staff member. I just finished my fellowship and was getting my master's in biostat. But now we have 200 faculty and staff dedicated to sharing data and their scientific, clinical, and statistical expertise with investigators globally. And the CIBMTR has produced about 1,400 peer-reviewed publications. So what? Did it change anything? Can you prove that this changed anything? Well, that's always a little bit hard to do, although every time we put in a grant application, we try. I'm just going to give you a few examples because a picture's worth 1,000 words. So I've looked for examples where we could have a really nice picture. And I'm going to take you back to the 1990s when unrelated donor transplants were being developed to extend the benefit of transplantation to the then majority of patients who did not get a transplant because they didn't have a matched sibling. There was some conventional wisdom at the time. And this was that A, B, DR, DRB1 particularly, and DQ were the most important loci to match. We were just beginning to have high resolution techniques to distinguish different HLA types, but it was definitely felt that mismatches that were detectable at what was then serology or intermediate resolution level were more important than mismatches that were detectable at high resolution. And that donor age was not so important, or not as important as things like donor recipient ABO match, sex match, and CMV status. One thing that was absolutely true is that the survival rate at 1 year was only 40%. And that was a lot lower than the survival rate with HLA identical sibling transplants. The first big study that really challenged some of this conventional wisdom was in 2004 in almost 2,000 patients. That first showed that HLA-C might be important. This study was enabled by the fact, in 1988, we didn't have methods really to type for HLA-C very well. And so we could retrospectively go back when not only we had the clinical data, we had the specimens, and lo and behold, it looked like maybe it might be important to match for HLA-C. We extended the study in 2007 in 4,000 patients. This definitely confirmed the importance of HLA-C and showed that mismatches only detectable with the recently developed high resolution allelic techniques were just as important biologically as mismatches detected with less sensitive techniques. Turns out that our immune systems are better than our old technology in understanding differences. On the other hand, it showed that DQ matching, once you were matched for A, B, C, and DRB1, really didn't matter. And this is a slide that's very familiar to transplanters that clearly shows that with increasing degrees of mismatch at these 4 loci, you have worse survival, especially obvious in early disease. So what happened? Well, if you looked before these studies, only maybe 35% had 8 of 8 matched. 30 to 35% of unrelated donor transplants were 8 of 8 matched, largely because no one was paying any attention to HLA-C. But after these, the number with unknown HLA-C, which is this line here, went way down. And currently, more than 80% of the unrelated donor transplants that are done are matched at A, B, C, and DRB1. We did a lot of other studies, and it's not quite as simple as that. There are some mismatches at A, B, C, and DRB1 that are permissive. And then, although individually less important, multiple mismatches at some low expression HLA alleles, such as DQ, DP, DRB3, 4, and 5, rather than DRB1, can have an adverse effect. Of particular importance seems to be DP, especially because you can segregate the matches into permissive and non-permissive on the basis of whether they occur within or across some very well-defined T-cell epitope groups. This was first put forward by Katharina Fleischauer in a small study in 2012, but then the CIBMTR did a big validation study in 2014. And what you can see is that before then, very few patients even had DP typed when they went to search for an unrelated donor. And this rapidly changed after that. And in just 8 years, you can see that the proportion of patients who went into transplant with DP matching unknown, this big went way down. And among the patients where DP matching was known, most patients were either matched or had a permissive mismatch. What about donor age? You can see that in the early days, the median age of unrelated donors who were selected for transplant to donate was 38, not the age on the registry, but the age of donors who actually donated. We actually published a series of studies on this, but the first was in 2001, showing that having a donor over the age of 50 was as bad as having a single locus mismatch. And what happened after, and that there really seemed to be a break point at 35. And what happened is you can see the change in the selection practices, so that the median age of donors in 2015 to 2019 was 28, and 77% were under the age of 35. And if we look at the data for this year, it's almost 85% of donors who actually donate are under the age of 85. In contrast, in all of these studies, the impact of ABO matching was minor. So why was the CIBMTR necessary for these studies? Well, it's all about statistical power, of course. Even combining all patients receiving all types of transplants for all diseases, the BMT population qualifies as rare. There's only about 8,000 allotransplants a year in the US, and it's hard to prove a benefit of 10% in small populations, even though it's clinically meaningful. And to do it, you need good data with which to do these analyses. And in this case, we also needed those stored donor recipient specimens to retype the donors and recipients with state-of-the-art techniques. So is this only important for rare diseases? Well, I would say that in cancer, everything's going to be rare eventually. As we get better at understanding the molecular basis of various types of cancer, we'll no longer, well, we already don't think of leukemia as leukemia or AML as AML, and we're not going to be able to think about all our solid tumors in the monolithic way that we have for a long time. And we're all going to have to deal with having to share data to address the problem of small numbers. And of course, I only showed you some of these of the studies that we did. We actually have 400 papers addressing various aspects of unrelated donor transplantation. But what I do want to show you is that the one-year survival rate from back that I talked about from back in the 90s has now improved to 70%, and it is virtually identical to the one-year survival rate after an HLA identical sibling transplant. And more than half of this improvement is due to better donor selection, and the amelioration of the difference between unrelated and related donor transplant is almost entirely due to better donor selection that was enabled by analyses of this large database. So sometimes registry data can socialize or disseminate a new technology rather than being involved in discovery. A really good example of this is these two New England Journal of Medicine articles that came out in 2004, one from the CIBMTR, one from the European Registry, that showed that umbilical cord blood had results similar to bone marrow in adults. Now, remember I said umbilical cord blood has a high concentration of blood stem cells, but they're small, so the absolute number is small. And they were becoming increasingly popular in children, but people were very nervous about using them in adults because of the low cell dose. But after the public, and you can see this is what was happening in kids, this was adults, and this is after the publication of those two papers. Sometimes the data tells you not to change. In the 90s, people started collecting blood stem cells by apheresis, from the blood rather than doing bone marrow harvests. And anyone who's done a bone marrow harvest knows why you'd much rather send your patient or donor to the apheresis suite, because it's time consuming and boring. And then you have to use general anesthesia or spinal anesthesia. And this became very popular despite some concerns about more graft versus host disease caused by reaction of lymphocytes from the donor against normal tissues. But it was slower to happen in children, but was starting to pick up. Until this study, and this is in related donors, that showed that peripheral blood grafts increase chronic GVHD particularly, which is the major cause of morbidity and mortality late morbidity and mortality after transplant. And this translated to higher transplant-related mortality and lower survival. And the pediatricians went back to using Marrow, which they still do. Different situation in adults because there's more chronic GVHD, but there's faster hematopoietic recovery. And so while chronic GVHD is higher, Generally, the survival has been the same. But there was a lot of questions about that. So the question is, wouldn't we want to know this in a clinical trial? Wouldn't we want to randomize peripheral blood and bone marrow? Well, I'm going to give you a comparative example. In our studies of peripheral blood versus marrow for adults who are getting unrelated donor transplants. That previous stuff was with related donors. I already talked to you about the relative merits of bone marrow and peripheral blood. In 2007, we did a very similar study to that pediatric study comparing unrelated transplants using peripheral blood or bone marrow in adults with leukemia or MDS. Showed more chronic graft-versus-host disease, but similar transplant-related mortality, similar survival. Still a lot of controversy saying it's observational data, you have to do a trial. So the BMT Clinical Trials Network, which was described already by Dr. Kaplan, so I don't have to, did a randomized trial. This one was supposed to include kids, but there were like six kids under the age of 18 in the trial. And this is what it showed. More chronic GVHD, similar transplant-related mortality, and similar survival. This is just all of that on a graph. And you can see here the treatment effects in the two approaches, and they're very similar. What was not so similar is the cost, because clinical trials are very expensive. But what about Sir Fisher's concerns? Well, we still have to be concerned. But we do have tools available that were not available to the average investigator in the first half of the last century. High-speed computers allowed development of regression and other techniques that can evaluate the impact of multiple variables on outcome. These were impractical when all computations were by hand, and they generally require large numbers of patients. And these same developments allow us to store and retrieve increasingly large and complex data sets. But bias and confounding are still possible. Not every question is approachable in this way. You need the right data to answer the question, the right techniques to model the process, and you have to understand and acknowledge the potential limitations of the results. Here's a few things that I've learned over the last 30 years of doing these kinds of studies. You're best off if you're trying to answer a question where you have a clearly identifiable objective starting point. So I like using this approach when we are looking at when day 0 is the day of transplant. In other settings, could be the day of first remission, the day of diagnosis, as long as the diagnosis is clear. It's not so good for looking at post-transplant things like treatment of infection, because every center varies in how they diagnose infection. You don't have a really clear starting point. So you need a clear starting point. You need some randomness in treatment assignment. If you give one treatment only to people who have Karnofsky scores less than 80, and the other treatment only to people who have Karnofsky scores greater than 80, you really can't compare those treatments. Now, because that's extreme. But there are differences. There are these patient selection factors that are sometimes so great that you can't really compare the therapies. You need a little bit of randomness. Fortunately, there's a lot of randomness in how people approach transplant, and sort of which transplant center you end up at is sort of a random assignment of the regimen that you're going to receive. You need good quality data on known potential confounders, a good understanding of what those are. You need adequate numbers of patients to allow use of those regression techniques I talked about. You have to make sure your outcomes are clear, not subject to bias, either ascertained bias or inter-observer variability. That's why I like death. There's no question about it. And you have to make sure the treatment cohorts are reasonably balanced with adequate numbers, not just overall, but in the clinically important subgroups of those confounders that you're trying to adjust for. So if 70% of the people in one cohort are over the age of 60, but only 10% of the other cohort are over the age of 60, you probably shouldn't do that comparison. You're not going to be able to adjust for age adequately. And you should be making those comparisons before you look at a single bit of outcome data, which is our approach at the CIBMTR. Some other things you can do with registry data is evaluate single arm trials with the use of, who knew there was a term called synthetic control arms. It was a big deal, a big article that got a lot of discussion in JCO Clinical Cancer Informatics about using Foundation Medicine and Flatiron, I think, to extract data from the EHR to construct a control arm for a trial. And what they showed is that they were able to do that and get a survival curve that looked just like the actual control arm of the trial they had selected. And I keep getting these things in my inbox that's going to try and teach me how to do this. However, actually, that was my master's thesis back in 1991, where we used the IBMTR data to compare transplant with data from the German ALL study group trial of chemotherapy for adults with ALL. We did a similar thing in 1994 using data from a pediatric oncology group trial to compare with data from BMT. Of course, that is ancient history. More recently, these are just two example protocols, example studies, and I chose them because both of them were included in submissions to the FDA. One using CIBMTR controls matched against a single arm trial of cord blood expansion done at MD Anderson, and the other two using CIBMTR controls to a single arm multi-center trial of abatacept for prevention of acute GVHD. Lots of ways to adjust for differences, whether it's an observational study or comparing to a trial. You can match on key variables, regression, propensity scores. I'm not a big fan, but a lot of people like them. You need adequate data and minimal risk of unknown confounders. One thing for sure is real world data can be very useful in planning trials. I'm just going to give you an example. You know, you're going to do a trial, and you're looking at the literature, trying to figure out which of several promising therapies you're going to compare to your control. Well, what's the problem? In the literature, all those phase 2 studies are around this size, and you can see that if you have a sample size of 30, you can be as good as 70 or as bad as 30 just by random variation alone. And of course, if you end up at 70, you publish, and if you end up at 30, you don't. So that is publication bias, of course. But even more important than that, patient variation from trial to trial may explain more of the variation in results than the therapies used. And we saw this in the BMT-CTN when we were trying to do our next big GVHD prophylaxis trial. And we had a series of investigators present 6 different strategies. And I'll just pick one of the outcomes. You can see survival ranged from 57% to 79%. So why didn't we just pick this one with the highest survival? Well, you look at the patient population in these trials, and you know, the age range from a median of 45 to 62. Some included only early disease, some included all disease status, and the numbers were relatively small, different graft sources, different conditioning regimens, different donors. So what we did was we took the CIBMTR data and we took patients who were receiving standard tacrolimus methotrexate GVHD prevention regimen, and using the patient level data, because we have data on all these patients in the CIBMTR because they're all US patients and they have to be reported to us. And then we did a Cox regression adjusting for these differences in patient characteristics, and found that 5 of the 6 had at least one outcome where there was signal, although the outcomes that were affected varies. We ended up with 2 randomized trials. One was a randomized phase 2 looking at 3 regimens that had been tested in the reduced intensity. I'm not going to go into this, but with low intensity conditioning, and then 2 that had we felt was pretty adequate data in the myeloablative setting. So this was a randomized phase 2 looking at these 3 regimens, and this was a randomized phase 3. This has been published. This is being submitted for publication. But I want to talk about the randomized phase 2 because we did actually have a synthetic control arm that we acquired prospectively. So we, instead of having a control that was randomized, we just randomized to 3 arms. That's hard enough to explain to patients. And then we prospectively collected additional acute graft versus host disease data similar to what was being collected on the trial, in addition to the standard data on a cohort of patients who were getting transplants at the same time, but getting standard GVHD prophylaxis. And then we compared each of these 3 regimens to those CIBMTR controls and found only one of them that met our signal criteria. And we have actually done a randomized trial comparing post-transplant cyclophosphamide, tacrolimus, and MMF to methotrexate. We've finished enrollment, but the patients are still being followed. And this just shows the survival curves. So the CIBMTR control arm is buried in here with 2 of the experimental arms. So where are we today, and what does this have to do with anything outside of transplant? Well, there is a growing appreciation of the power of data, lots of data to generate knowledge. I mean, when I started, the computer was a big machine in the other room. The printer was a big machine in the other room that jammed all the time. And you had to have an engineering degree to figure out how to get it to start again. Except I did figure it out one weekend when there was no one around. Now we all have computers in our pockets, and we all expect to have the data we want when we want it. We have new machine learning techniques and novel statistical approaches that are powerful tools for iterative learning to refine diagnostic and therapeutic strategies. And we have the ability to link with all sorts of data that we didn't even dream about when I was starting 35 years ago. The scale of data available is almost mind-boggling. Now, in the CIBMTR, the whole CIBMTR database is about 1 terabyte of data. But that's not really what we want. We want 1 terabyte in every patient, right? Or close. And of course, the more detailed the data, the more valuable, the more real-time, the more valuable. We're never going to get that if we are limited to data that someone has to enter on the screen. So we have to link. We have to link to electronic medical records, to other kinds of databases, tissue repositories, and eventually to devices. But the fact is that data collection for research is still largely a manual business. And we're all bombarded with increasing demands for data and decreasing resources to support data management activities. As I said before, the EHR was not designed for research, and the hopes that it would feed new analytic tools, while proof have been established as proof of principle, those hopes are still largely unrealized. And research is not, the one thing I hold against Obama is he didn't establish research as a meaningful use, because we would have made a lot of progress if it had been one of those original meaningful use criteria. And of course, who's entering the data? The people who are too busy and too distracted to do it well, busy clinicians. And then there, of course, is issues of consent, privacy, data security. My big concern, I mean, we defined big data by volume, variety, velocity, and veracity. That is my worry. Accuracy for doing medical research is more important than other uses of big data. I mean, if Amazon analyzes your buying practices and recommends to you a book that you have no intention of reading, who cares? But if we analyze the EHR and with incomplete or inaccurate information make a wrong recommendation for treatment, well, that's important. The incompleteness of the EHR has been demonstrated over and over again. I don't care what your software is like. If it's not there, you're not going to capture it, even with natural language processing. There's a zillion point of care errors and substantial inaccuracies compounded by copy and paste. I shouldn't get started there because that's one of my pet peeves. So we not only have to develop the software to extract data, we have to work on getting data collected in a way that's consistent with national data standards and are suitable for research. We have a number of initiatives. We've worked with EPIC and with CIBMTR has actually been instrumental in getting, and also the American Society for Transplantation and Cell Therapy, to get GVHD flow sheets, infusion flow sheets, apheresis flow sheets for recording the HCT comorbidity index. There's a BMT smart form, and I don't know if it's released yet, but there's going to be there will be any minute a cell therapy smart form. But really what we need is to have a different way of getting the data in. I mean, why aren't we taking our army of data managers and have them enter data appropriately in structured fields in the EHR, which we then can pull out, rather than having them sitting in front of two screens and pulling it out of one database and manually putting it into another. A lot of that is because the hospitals won't let those people touch the EHR. New technologies will help natural language processing, but those tools are still expensive, proprietary. They still require you to have accurate data to mine. Particularly good though for things like path reports. There are increasing availability of public tools such as HLA7 FHIR, and that can really be helpful in pulling data out, but you still have to get into your hospital's IT queue. And I don't know about whether it's different in Miami, but in Milwaukee, it's hard to get on that queue if you're asking for something that's not related to billing or clinical workflow. And then, it's not that there aren't data standards, that everyone's using different ones. That said, I'm a transplanter, so I'm an optimist. There is progress being made. Most large academic centers have or are developing clinical data warehouses that get at least some data out of the EHR, and some are part of networks that share these data across centers. There's increased availability of commercial tools that are either embedded in the EHR, such as Epic's Caboodle and Slicer Dicer, and there are others that are put forward by other commercial entities such as Flatiron and Trinetics. CIBMTR is itself in the second year of a data transformation initiative to capture structured data from the EHR and US centers. Last year, we established proof of principle. It's a vendor agnostic system, so it can be Epic, Cerner, or if you're already putting something in your own local database, we'll take it from there. And we are expanding it this year. And there are some state cancer registries working to gather data directly from EHRs, but it's difficult and it requires resources. ASCO has worked closely with others in the field to develop some consensus data standards for oncology that are particularly suited for providing data to registries. And then we have new techniques for data analysis. They range from things where you kind of know what's going on to these black boxes with neural networks and nonlinear relationships. Everyone's really enamored of these. You just want to put something in a box and come out with gold on the other side. And I'm not saying it doesn't work. It's not saying it doesn't work. It's a little bit harder to interpret, and it's not always the best way. There was just this big study looking at machine learning to predict tamoxifen compliance. And they looked at all these techniques and they decided that the best model was old-fashioned logistics regression. So sometimes new is not always better. So what's the future in my hopes, my dreams? It's a little tricky to make predictions. I love this one in particular, 640,000 bytes of memory. Can you imagine how fast you'd go through that on your iPhone? Someday, I do believe that the EHR data will be complete, reasonably accurate and accessible, and fit for research as well as clinical and billing purposes. Of course, I will be retired by then, for sure. I think that with that, we are going to be able to share data from many institutions. It will become routine without thousands of hours of manual effort. That cancer registries will have detailed, timely data and become more useful tools for research, and that this model will be extended to other diseases outside of cancer. And what I would really like to see is that clinical trials networks become embedded in registries of their target populations that integrate EHR data with data from other sources, with some trials being run entirely with registry data, others complemented by registry data, but all trials taking advantage of real world data for design and for follow-up. So with that, I've left a few minutes for questions, and I do want to thank you for your attention and for the invitation to participate in this grand rounds. I also want to thank our parent institutions, be the Match, Medical College, our funders, but particularly, every patient in this registry has given consent for use of their data, and some instances, they're specimens for future research, and we have to acknowledge that generosity. And also, because I know that some of the people who do this are on this call, I know that we don't pay enough. We don't compensate all the work it takes to get the data into the CIBMTR. We hope we get value added, but I do want to acknowledge all the clinicians, scientists, and research staff at hundreds of transplant centers who work to make these data into a valuable scientific resource. So thank you for your attention.
Thank you so much, Dr. Horowitz. We have a few minutes for questions. So Dr. Clemenduri, Dr. Zakaris, would you like to lead?
Mary, first, thank you. That was beautiful. I always learn a lot when you talk. By the way, the 1990 Nobel Prize was the same year that you wrote your, I think, seminal GBL paper. So I don't have a hard time remembering that Don Thomas Nobel Prize.
Oh, well, let me just tell you, the high point was he asked me for a slide for his presentation.
Oh, wow.
I mean, I was like, yes, this is great.
I want to actually ask a little bit more focused question, because you raised really high level things. One of the things that we want to know is, when should we use CAR T cells versus auto transplants or other things? And I wanted to actually just ask you to kind of comment on a very recent example, which is the paper from your institution, from AD and from the CIBMTR, about the role of auto transplants versus CAR T cells in patients with a PR, right? We are limited. We don't have any randomized trials in CAR T cells. We certainly don't have randomized trials, and we have obviously some trials are emerging that have some limits in trying to figure out in first patients. But you want to comment on that, and on that specific study, and how we might help to decide between different types of technologies, as opposed to within one.
Well, I think what that study shows is that it's not time to toss auto transplants out just because we have a new therapy.
So most people on the call on here on this thing won't know what we're talking about. So if you want, can you just?
Yeah. So auto transplants, for lymphoma are an accepted approach where you dose intensify alkylating agent therapy to a dose that will cause irreversible marrow toxicity, and then you rescue the patient from that marrow failure with stored autologous cells. And it has been used successfully with a number of studies showing that it provides cure in some patients incurable with conventional therapy. CAR T cells are genetically altered T cells that target surface marker of lymphoma. It's not tumor specific, but it's you can live without it on your normal lymphocytes. So it's a targeted cellular immune therapy, and it's new, it's sexy, but it's not necessarily better. And I think that there are going to be some data presented at ASH. This might be a setting. There's a lot of differences in the patients who are treated with CAR T and the patients who are treated with auto transplant. I think in this setting, when you have a developing technology, these studies are really good to give caution, to raise questions that should be followed up with better controlled studies. And remember, CAR T is just evolving. So the results today may not be the results a decade from now, but we need to be looking at it constantly. And we also need to be following these patients long term, because the one thing we don't really know that we do know with auto transplant, because we have decades of follow-up, is how durable the remissions are. And that is a really important role of the registry in terms of maintaining follow-up on these patients who disappear from the trial view after 3 or 4 years. So I think in terms of use of a registry to evaluate new technology, that's a really important use, and to understand what the late effects might be. What's your perspective on what that study shows?
No, I guess one of the frustrating things for me is that, for example, people, even payers, are starting to think about contemplating decisions between Tisagen, Leqvicel, or Axi-cel, that we as clinicians would say, you can't make that decision. And there's so much selection bias and so many differences between the pivotal trials and these other things. So I do think one of the values of extraordinarily complex registries and the kind of multivariable assessments that you talked about is helping us in the best way possible without the true face-to-face RCT, how to make those decisions. And I think you articulated that well. So again, I think the jury is still out, but I think it was a very compelling paper, obviously, and should raise a lot of eyebrows and provoke further research.
Yeah.
Well, thank you so much. I don't know if anyone has a quick 30-second question, Dr. Zakaris.
Very, very quick. Mary, as usual, awesome, incredible. And your perspective on the use of databases for clinical research is amazing. I mean, I see numbers like you presented where you have information on over 500,000 patients over time. The question I have for you is kind of a broader one. As you have databases that are that huge and that potential for powering the study, how do you make the distinction in saying, yes, we're going to actually look at this question between what's statistically significant because you have huge numbers and what's clinically meaningful? So where is the equipoise in doing that?
Yeah, I think you make a decision on whether you're going to do the study based on whether you want to know the answer. And then when you have a lot of patients and you have something, I always say, strength of association is not everything, which is measured by the p-value. You have to look at the magnitude of the effect, and you have to discuss that. And we have studies where there are small differences that reach our statistical significance, but like, who cares? If it's 3%, is that gonna alter therapy? But the decision to do the study has nothing to do with the results. It has to do with the question and whether you can answer that question adequately. And that means you have to look at carefully at the population you have available for study, make sure it's reasonably, if you're, for example, doing 2 treatments, reasonably comparable so that you can use your statistical techniques, not likely subject to ascertainment or observer bias, and make those decisions up front before you even know what the outcome says. And also adjust for multiple comparisons, because these techniques, you're looking at a zillion variables. So 1 out of 20 is going to be significant. So we always do that. And most studies we're using 0.01 is significant, not 0.05.
Well, thank you so much. I'm sorry we're a minute past time, so thank you everyone for joining. Thank you so much for Horowitz. In the chat is the CME and MOC that you can click on. And as a quick note, we don't have grand rounds next week, so we'll be reconvening with geriatrics and ID on the 13th. So thanks everyone for joining.
Thanks for inviting me.
Thank you, Mar. Thank you, Mary.